So next is V26 lower limb traumatic vascular injury. 26-year-old male sitting in his car with a pistol in his pocket accidentally fires a round through his thigh that exits medially to the knee joint. How will you manage him? So I will approach the patient with ATLS guidelines. If it's any pulsatile bleeding or revealed obvious, I will put a pressure or do a proximal tourniquet. Then I will examine airway, breathing, circulation, and then I will, after doing primary survey, I will do secondary survey and do neurovascular examination and look at the hard signs of vascular injury. So what are the hard and soft signs? So hard signs are pulsatile bleeding, rapidly expanding hematoma, absent distal pulses, cold limb, palpable thrill, audible bruit. Soft signs, bleeding from the wound. How will you investigate him? So he should have CT angiogram with delayed peripheral vessel runoff, but CTA will show the level of arterial injury and help guide surgical planning and level of incision. Do not necessarily delay the revascularization by undertaking needless investigations and waiting for the report when the patient has obvious hard signs of vascular injury, particularly if there have been any delays in the transfer to the hospital. How will you revascularize an ischemic limb secondary to an mid-SFA traumatic injury? So I will explain to the patient about harvesting the long stiffness vein from the contralateral limb, fasciotomy, and I will warn him about the possible risk of limb loss as well. I will position the patient on the operating table, prep from umbilicus to the ankle, both sides, and always to get proximal control. Let's get groin exposure and control of common femoral artery, profunda femoris artery, superficial femoris artery, and if tourniquet with the blood, it needs to be removed. And then I will go from the middle side of the thigh where the gunshot wound is. I will explore the both ends of SFA and do debridement, and then get control of both ends, and I will make ready the both ends adequate for the anastomosis, and then we will see harvest the long stiffness vein, prepare it, and reverse the contralateral long stiffness vein for proximal and distal anastomosis, and consider fasciotomy. And if there are so many patients with the limb injury, then you can consider the shunt placement and then revascularize later on. And if patient has bone fracture with the vessel injury, so shunt the vessel, let the external fixator fix the bone, and then revascularize. Thank you.